So thank you for coming. This is sponsored by the Association of American Physicians and Surgeons. It is the largest free market group of physicians and surgeons in the country. We're honored today to have Congressman Paul Broun here to discuss the Patient Option Act and the legislative solution that he sees to Obamacare, and as an association, the Association of American Physicians and Surgeons sees. We also have Dr. Doug Nunemaker here from Wichita. He is going to share with us the entrepreneurial solution. He's actually runs a direct care practice in Wichita, but they're doing things that are in a different way than I've ever heard done, and at prices. I'm a Kansan. So in Kansan we have a lot of farms, but that also means we also often don't have a lot of money. And he's created a practice and a system and an EMR that can handle both of those. Then we have Sean Parnell. He's the writer of a book called The Self-Pay Patient. If you want a copy, we have a few on your way out. But he's going to share what the individual can do to, you don't even need to Obamacare in place. In a normal system, how an individual can take care of themselves. So without talking too much, I want to get out of the way and introduce Dr. Paul Broun.
Thank you, Charlie. We're going to provide some notes for you to compare the three major bills that have been introduced here in Congress about health care reform. You'll get a sheet like this. My press secretary has some here, and I'm not sure if we have enough, but we'll probably need to get some more. But if y'all could pass those out. The Patient Option Act, which I actually introduced it prior to Obamacare ever becoming law. I'm an original intent constitutionalist, and I believe in free market solutions. I believe the marketplace, unencumbered by taxes and government regulations, is the best way to control quality, quantity, and cost of all goods and services, including health care. It doesn't matter what product it is, what service it is. I think the health, including health care, opening up the marketplace is the best way to go. I'm a primary care physician, a family doctor. Practiced medicine in Americus, Georgia for 23 years. I was in Blakely prior to that for a couple, all down in southwest Georgia. And then we moved to Oconee County, Georgia, just outside of Athens, where we live now. I was in an office practice, and then for 5 years prior to being elected to Congress, I was doing a full-time house call medical practice. It was basically on a cash basis. I saw patients that are on insurance. I saw Medicare and Medicaid patients. I would collect from them at the time of service. If they could pay me, fine. If they couldn't pay me, fine. And it was a wonderful type of medical practice, very similar to the kind of medicine that I was practicing when I was first went into private practice a number of years ago, before all y'all were born. So the private practice of medicine is where I came from. And I wrote the Patient Option Act based on what I knew was the best market-based practice, so that it would empower patients and providers to give the kind of quality health care services that I was trained to do and the doctor was trained to do. And so that's what I approached the bill to try to put in public policy, because as a practicing physician, I knew that what was going on in the healthcare world just was not working for my patients. It was driving up the cost of our insurance. It's driving up the cost of all medical bills, whether it's a hospital bill, doctor bill, or durable medical services, or anything. Everything involved in healthcare delivery was being rapidly ramped up in cost because of the federal government and federal intrusion into the healthcare system. So I wanted to get the federal government out of the healthcare system and to let those marketplace pressures come to work and empower you so you can make your own healthcare decisions. We wrote the Patient Option Act prior to Obamacare becoming law. Once it did become law, I added repeal language. The first bill is 52 pages. The current bill is 77 pages, and that's the repeal language. You can read it, you can understand it when you read it. You don't have to pass it to understand what's in it. And it does a number of things, and I'll just kind of go over those. You'll all have a grid here that you can look at mine. And mine is the only bill that totally gets the federal government out of making health care decisions. And is the only totally constitutional bill that's out there, according to the original intent of the Constitution. Now, I have to explain that to you because most people here in Congress say they're operating constitutionally, when the reality is they're operating on an idea of the Constitution that's very adverse to what our Founding Fathers meant for it to be. And what I mean by that is our Founding Fathers meant for Congress to only have 18 things, some would say 20, I won't quibble between the two, only 18 to 20 things that we can vote upon. 18 to 20. Obviously, we were voting on a whole lot more than 18 to 20 issues, and healthcare is not one of those 18 to 20. The power and scope of the federal government has been expanded tremendously by utilizing the Commerce Clause, the General Welfare Clause, and the Elastic Clause principally to expand the size and scope of government. And we've got to demand a different kind of governance if we're going to lower the cost of health care. If we're going to put you in charge of your health care decisions and Americans all across the board. I believe very firmly that we can lower the cost, markedly lower the cost of your health insurance, of your doctor bill, your hospital bill, all medical bills by getting the federal government out of making health care decisions. And the Patient Option Act was geared to do that. We did several things in the bill. For instance, we made all health care expenses 100% tax deductible for everyone. And what that'll do eventually, it'll get rid of managed care, doctor. I think it's going to totally eliminate managed care because the employer-based health care insurance or health care financing, which most Americans are under, actually stems from law that was put in place during World War II. And we've long outlived that type of philosophy. And we've got to give patients the ability to buy their health insurance on an open market at a much lower cost. And by making health care insurance tax deductible for everybody, it means that your employer doesn't have to buy your health insurance for you, and your employer can just give you the money so that you can go on the open market. We create what are called association pools. An association pool could be anything. I'm a Rotarian. For instance, Rotary Club International could establish a healthcare pool. So anybody who's involved with Rotary International or has a family member or anybody, however they want to set it up, could join their pool. And the Rotary Club International pool could offer a smorgasbord of healthcare insurance plans. You'd have these huge pools nationwide, so you got to spread the liability across a greater number of people, thus lowering the cost for every single individual. And you could join the pool. And what difference between mine and the other Republican bills is CMS controls the federal government controls the insurance pools of all the other plans. With mine, Rotary International would. We could have a government employees healthcare pool that any government employee, and it could be set up in a private sector where any government employee or any previous government employee could join that pool, which would, you can just imagine how big that would be and how much it would lower the cost. We not only deal with opening up the market through your being able to own your insurance, which solves the portability problem because everybody owns their own insurance and they take it wherever they go and they buy it and they make their own healthcare decision or health financing decisions. An employer won't do that. The government won't do that. The person themselves will do that. We do some other very unique things that's not in any other bill. For instance, we give providers a tax credit for providing indigent care, which means during my practice of medicine, I've literally given away hundreds of thousands of dollars of my services to patients who just couldn't afford pay me. And in fact, prior to coming here to Congress, I was doing a full-time house call medical practice. It was glorious. I really loved doing it. I'd go see my patients or home, at work, or wherever they needed me to come. No longer office-based. I worked out of my GMC Yukon. I had a leather black bag that Eli Lilly Company gave me when I graduated from medical school, and so my whole practice consisted of my GMC Yukon, my black bag, and me. I'll tell you a funny story, just kind of get off on the, make a little rabbit trail here. When I came to Washington, I had a reporter, I think it was from Politico, a young lady came and was talking to me about my house call medical practice, and I told her that my practice consisted of my Yukon, my black bag, and me. When she printed it, it came out as being my Yukon, my BlackBerry, and me. She had no concept of what a leather black bag was. So most people y'all's age have never seen one. But anyway, back to the story. We do give a tax credit to physicians to provide indigent care. Also, we give individuals a tax credit to provide money to any local hospital or clinic that provides indigent care also. And I'll just give you an example of how this works. In Athens, Georgia, where I live, there's a clinic called Mercy Health Clinic. There's another one. I've actually gone and worked on a volunteer basis. We have 70 physicians, 70 or 80 physicians in the Athens, Georgia community that go to Mercy Health Clinic and just see indigent patients. A lot of these are undocumented patients. A lot of them are just poor folks. And we go and we don't get any remuneration for our services. We do it because that's what doctors do. Mercy Health Clinic has a hard time getting people to contribute because of the high taxes and because a lot of businesses and a lot of entities look at the government as providing health care for these indigents. And we've got to change that mentality. So what we will do now, if somebody were to contribute money to Mercy Health Clinic, they get a tax deduction today, which just means it just lowers their tax burden a little bit. But with my bill, the Patient Option Act, what we do is give a tax credit for that deduction. And that means it takes it right off the top. And you think about what I'm doing there is I'm taking money out of the hands of the bureaucrats in CMS and putting it where it should be, and that's taking care of patients, instead of fueling a huge bureaucracy up here to tell us how to practice medicine. It does EMTALA reform. EMTALA is the Emergency Medical Treatment and Active Labor Act, which was passed a number of years ago. It requires every emergency room to see and treat anybody who walks in the door. And emergency rooms have been just inundated, particularly since ObamaCare, because emergency rooms are being utilized as a primary care clinic for people who don't have insurance, and they think that's where they should go for primary care. I've worked in emergency rooms, and if you go to any emergency room in this country, you see it packed, particularly down my part of the country in Georgia, is packed with undocumented people in this country, primarily. But then other people, poor folks, go to the emergency room, and anybody who walks in the emergency room today is evaluated and treated. And what's happening in the hospitals because of that attack upon their emergency rooms, it's the most expensive, least efficient way of providing care. So people go there for a sore throat or for the flu or to get a stomach bug. And they shouldn't be in the emergency rooms at all. And what we do is we reform EMTALA so that hospitals can set up some basic screening. And it doesn't have to be a physician. It could just be an EMT, emergency medical technician, could evaluate them. And a lot of these guys, or we could use our veterans. I just got out of the Navy Reserve as a doctor. Recently, I was deployed to Afghanistan in 2012. I was over there as a physician taking care of sick and injured Marines and soldiers. And I was working with Navy corpsmen, as we call them in the Navy, they call them medics in the Army, but some of these guys are extremely well trained to take care of patients and evaluate patients, but the hospital could set up a basic screening for patients coming there, and if they don't have a true emergency or if they're not in active labor, then they can be sent out and go to Mercy Health Clinic there in Athens. Instead of having to go to the St. Mary's Hospital or Athens Regional Hospital, then the basic screener could say, well, there's Mercy Health Clinic, it's just 3 blocks down the road, or there's Athens Neighborhood Health Clinic, which is another one in the community, where they could go. So it's going to change the dynamics of healthcare provision as well as financing. Now, we hear all the time that Obamacare is the law of the land. It's here to stay. Let's just tweak it and fix it. Well, I disagree with that. And in fact, before Obamacare was ever put into law, I went to the floor of the House and over again it said that Obamacare is designed to fail, and it really is. We had, could see hands of any of y'all who were here during that discussion when Obamacare. I know Sarah was, it just 2 or 3 of you, but during that discussion, really from the Democrat side, remember there was no Republican whatsoever that voted for Obamacare. It was all totally Democrats. And there was just really discussion about 3 issues where we're going to have what they call robust public option, which means they were saying that's Medicare for all, or whether we're going to have a public option, which is basically what we see through the government, through healthcare.gov today, or whether we're going to have a government or public option light, which meant that people could have their own private insurance, but it would be provided through the state exchanges and that sort of thing. And obviously what we came up with was Obamacare with the public option light. But it's designed to fail. The president has been very clear where he wants to go with healthcare delivery. Been extremely clear. He believes that we ought to go to a single-payer system. And that's what it's geared to do. I believe that the whole idea from the Democrat side was that we'll get enough people dependent upon the federal government to help pay our health insurance through the subsidies that once it does fail, that we would have a vast segment of our population clamoring to go to a single-payer system. That's what the leadership of the Democratic Party all along have said. That's where they want to go, and that's what Obamacare is designed to do, in my opinion, is to try for it to fail as it is today, to go to a single-payer system. So what are we going to do about it? Well, there is an option, and it is the Patient Option Act. We've got several other Republican bills. You'll see on the handout what we're going to give you, the other bills that are out there. But mine, again, is the only one that truly gives you the ability to make all health care decisions. We've got members of Congress that say, in fact, we've got one who from Georgia has said that he thought it was irresponsible to let Obamacare fail. I think it's so irresponsible to leave it in place. And the only way we're going to get something different from the federal government running health care is for you guys to talk to your boss. I hope all of y'all will go, and it's H.R. 2900. I hope you'll all go and get your boss to look at the bill, and let's start trying to promote it, because it is the only option. Long term, it's the only option that's going to allow you to make your decisions in what kind of health care delivery that you get, and be able to buy health insurance and go to the doctor, go to the hospital, or buy medical equipment or pharmaceuticals at a price that most Americans can afford. So that's what I'm all about. I'm not going to be here in the next Congress. I ran for the Senate, was unsuccessful in the Republican primary, but I hope somebody else will pick up the bill and carry it forward. I'm going to depend on AAPS, the Association of American Physicians and Surgeons, to help promote that in the next Congress until we can get it passed into law. Just want to read a quote for you. The Federalists, when they evaluated plans, they evaluated 6 health care plans. They gave they gave the Patient Option Act the high score of 97%. And this is what they said, quote, "By any measure, Brown has set the gold standard. He embraces the right goal, follows sound principles to their logical conclusions, and definitely avoids mandates, tax hikes, constitutional violations, and politically risky disruptions. At the same time, he manfully tackles Medicare and Medicaid reforms with refreshing simplicity. This is what real reform looks like," unquote. We do deal with Medicare and Medicaid. I don't have time to go into all those details. We're giving you the sheet. I wanted to give you some highlights about what the bill's all about. Please look at this. Please carry it back to your bosses and talk to them about it. This is the kind of policy that we need to long-term put into place, is the Patient Option Act. I thank y'all very much, and I thank you, Ms. Sauer. I appreciate it.
Thank you.
Appreciate it. Thank you.
Thank you.
Yes, sir.
Doug.
Like you said, my name's Doug Nunemaker. I'm a family physician from Wichita, Kansas. Family medicine trained, board certified. Wanted to mention a couple things, actually, what Dr. Brown was saying. Because of big pharma rules, insurance companies aren't allowed to give physicians gifts anymore. So his Eli Lilly bag, that doesn't happen anymore, but I digress. Something else with EMTALA. It actually doesn't, in the bill itself or in the law, it says that a medical screening evaluation, which actually isn't defined, it just says someone that the hospital appoints to do it will do it, but it doesn't define what it is. Everyone needs to be screened and stabilized. So if you're in labor, if you're having a heart attack, something like that, you need to be stabilized. But it doesn't actually say you have to be treated anywhere. So a lot of ERs are actually going to some sort of a copay. If you're screened and you have let's say you have a broken toe that's otherwise not emergent, you can be treated, but there's going to be a certain copay to come back and actually have that done. That's just to offset some of the high costs from the ER, but again, I digress. What I want to talk about is how direct primary care, which I'm sure a lot of you are familiar with the term concierge medicine. Concierge, kind of the royal pains. Anybody familiar with that? Very expensive way to deliver care. Sometimes $10,000, $20,000, $25,000 per year per patient in order to have your own private physician. It's not very applicable to the masses. So anyone that targets 1% of the market can only ever expect 1% of the market, and it doesn't really work on a national scale. We all understand that healthcare is broken, so how do we fix it? And Josh Umber, my partner at Atlas MD, decided that the main step, the main thing that we found that was wrong was trying to pay for primary care with health insurance. And we liken that to trying to pay for gasoline using car insurance. It would be your car insurance would be a lot more expensive. The insurance company would tell you where you could get gas. You wouldn't know how much you're paying for gas. The person at the pump next to you would have a different price because they have a different policy. About 2 to 3 months later, you'd get your explanation of benefits. It would tell you how much you actually still owe and how much they covered. You'd have to pre-approve trips out of town. Nobody would do it. We just pay for gas because it's affordable, so we don't insure it. If you need paint for your house, or nails, just buy those. You don't insure them. Why we insure primary care doesn't make sense at all. Insuring things like heart attacks, cancers, car wrecks, surgeries, that makes sense. Those are expensive, but primary care is not. So the way we developed our clinic was to remove primary care, the payer source from insurance to the patient. And we work on a monthly membership fee. So children are $10 a month, and then most young adults are $50 a month. And that's it. And it's unlimited care. You can come into the office as much as you want. It includes no copays. It includes text messaging, email, phone calls, after-hours visits, home visits if needed, and I have the same little black bag, except I had to pay for mine. But I make house calls still, and no insurance involvement. I don't have to try to bill or code to justify an insurance claim for the patient. We remove all that. We also offer procedures for free. So biopsies, laceration repair, EKGs, bone density testing, strep throat testing, urinalysis, you name it. Anything I can do in the office, I'm going to include. I could do an EKG on you and charge $25, make a little bit of money, but you don't know if you need it, and every time I order it, it's just a bunch of squiggly lines. You're going to wonder, is it because I'm making money or because the patient needs it? So we wanted to remove that question of, if I take my car to get my oil changed and they tell me my blinker fluid's low again, seems like every time I go in, that's, you guys are doing that. Is it to benefit you or me? So we wanted to remove that from the patient's, the financial incentives needed to be removed. We also offer wholesale medications, lab work, and imaging. So in all but about 4 or 5 states, Texas, New York, and a few others, physicians can dispense medicines to their own patients. When Walmart came out with the $4 list, it radically changed how people bought medicines. Now, their incentive, obviously, is to get you into their store, but I can tell you that they're still making money even though the medicines are $4. A medicine, Lasix or furosemide, $4 for 30. Well, I get 1,000 of them for $10. So I can dispense it at literally a penny a pill to my patients, so it's 30 cents. Yeah, you save a few dollars here and there, but let's look at a medicine like Prilosec. If you're getting that over the counter, somewhat expensive, I get 1,000 of them for $58. So for about $2.50 a month, I can treat people for reflux. Even better, Topamax. It's a wonderful, or topiramate. It's a great migraine medicine to prevent them. I had a new patient, she hadn't signed up yet. She has 2 daughters, both are on Topamax for their migraines. Costs $90 per daughter per month for medicine. So she's spending $180 per month just for medicine. Well, I get the same medicine for $6. So her $50 plus 10 and 10 for each of the daughters, so we're $70, plus the 12 for their medicine, $82. So we're $98 less expensive, and they can see me as often as they need for the entire month. So I've actually made her $98, and she has a doctor. So you're going to start to make some impacts like that. We've saved money even on people that were going to community-funded free clinics. We're less expensive than them, all because of the free market. Labs, same thing, blood work. A blood count, looking at white blood cells, red blood cells, things like that. You can go to a lab, they might charge you $30 or $40. If you get that same test in the ER, it might be a couple hundred. Again, price inflated because they know a lot of people aren't going to ever pay it, so they have to make it expensive. We do it for $1.87. So we can do routine labs, and again, if you are on a medicine that requires chronic monitoring, we can do it much, much less expensive. I can do a CT scan for about $175, CT head. So if you're having headaches, the worst headache of your life, you might have bleeding in your brain, you can go to the ER, have a CT scan, it'll be about $1,800, $2,000 for the whole visit. Or you can come see me for your $50 that you've already paid, plus $175, and I can tell you if it's a problem or not. So all of that is what we do. But we realized, again, we need to wrap in insurance. Insurance isn't the enemy, we're just going about it wrong. So a high deductible plan, and again, the fact that we even call them catastrophic plans makes me, it's amusing. That's what insurance is for, catastrophes. You don't say, again, you don't have catastrophic homeowners insurance, you just have homeowners insurance. So wrap in a high deductible plan. Take out primary care. That's sometimes 40 or 50% of the policy. So I've immediately reduced your premium by half. Even when you add in back the cost of my services, you're still not back to where you were. For instance, a company called Johnson's Garden Center in Wichita, it's a 4th generation family-owned gardening and landscaping company. They were looking at a 20% increase in their insurance, and they had cinched up their belts as much as they could and basically said, we can't cut anything anywhere else. We either need to stop, this was 4 years ago, so we can either stop offering insurance or we have to let some of you go. Not desirable either one. So we came into, why don't we see what we can do? Let's add in our clinic and rework your insurance. It went from what they were paying to 50% less than that. And again, they were going up by 20% to 70% less than what they were looking at. They actually saved so much, even after they added in our clinic, they gave everyone a raise. So not only did they not have to let people go, they gave employees a raise. And I was on NPR once a couple of years ago and asked any caller that was listening or anybody was listening to call me if they ever heard of a physician's office that allowed a company to give their employees a raise. And I still haven't gotten a call. So that's what you can do when you're really working for the insurance companies for the right way, I mean. So patients have lower premiums. I see less patients. That's part of the thing. Most family physicians see anywhere from 2.5 to about 4,000 patients. That's what it takes to keep the clinic running. Because if I don't have a patient in the room, I can't bill insurance, can't make money. There's a physician's office just south of Wichita in Ark City. 6 physicians, has 62 employees to make it work. So you have to pay all of your bills and 62 people before any of the physicians can actually take home any money. And I only have but one thing to sell, and that's my time. Just like a plumber or a mechanic, there's a certain amount of time and a skill that I have, and that's all. So if I'm seeing a patient every 7 minutes, I'm not delivering quality care. So patients get better care, they save money. Insurance companies actually are more profitable because they're selling more plans because they're less expensive now, more people can afford them. I cut out 40% of what they pay, which is primary care, but I cut out 80% of their administrative overhead, which is dealing with all of the coughs and colds and sniffles. So insurance companies are more profitable and offer better quality plans. Companies can operate more efficiently because their patients are now healthier, they can stay at work longer, and they're spending less on their care. And physicians end up being happier. We've saved several from potential retirement. We're more profitable in our clinic. We have 3 physicians and 1 full-time nurse and 1 part-time nurse. So that's our staff compared to the one just south of us. So in the end, when you do free market medicine and actually apply all these principles, you can do some really pretty amazing things. Trying to think if I missed anything else. I don't think so. And if any of you guys have any questions, I'll be here for a little bit afterwards. But if you want to know more about us, you can get on our website. It's atlas.md/Wichita. And yeah, thanks for your time.
Thank you.
Sean. I want to first thank the Association of American Physicians and Surgeons for having this event. I think it's important to talk about free market healthcare, not just to promote it, but to explain what it actually is. And that's kind of what I think part of my role is today. If there's one thing that I want you to walk out of here understanding and remembering, it's that free market healthcare is not just a theory, it's not just an idea, it's not a collection of policy papers from think tanks, it's not something that maybe sounds good on paper but hasn't really been tried in practice. Free market healthcare is something that is here today. It exists, it is thriving. Millions of Americans participate in this free market for healthcare, and for the most part, people like me who are advocates of free market healthcare, this market that exists today is performing basically the way we would expect and hope for a free market in healthcare to operate. I want to point out that when a lot of people talk about free market healthcare or have concerns about it, what they think that we have today, the dominant system, they think that's free market healthcare. They think, well, there are insurers and they're for profit. There are drug makers, they're for profit. The doctor's offices, they're all private practices, they're making profits. Well, okay, if there's profits, that's the free market. That is not at all the case. The dominant healthcare system that we have today has several features that are completely the opposite of what you would see in a real free market. The most significant one is probably the fact that the government sets the prices for about half of all healthcare delivered in America. And the other half of healthcare, for the most part, the prices charged in that sector is largely influenced by those government price controls. That's not the free market. In a lot of states, certificate of need laws will prevent somebody who wants to build a new surgical facility or an imaging center from opening if the government doesn't think there's a need for that service. That's not the free market. Tax policy over the last 70 years has driven this third-party payer system, which means that the individual consumers of healthcare have no real idea how much anything costs, and they don't really have any reason to know how much it costs because they're not picking up the tab. The insurance company is. And for the most part, the primary mechanism for financing healthcare in America today, health insurance, is a product that is designed by the government. What benefits are available under what conditions. There's very little differentiation. There's some minor variances. A Blue Cross plan is not exactly like an Aetna plan, but it's pretty close. There's just not that much differentiation. You can't innovate. If you want to offer an insurance product, it has to meet the approval of the government. None of those things are what you would find in a real free market. So if the dominant system today is not a free market, what is? Well, what I would suggest to you is that the self-pay market is the free market in healthcare. The book I wrote is called The Self-Pay Patient, and essentially the definition I use for a self-pay patient is anyone who is paying directly for some or all of their care. A lot of these people are going to be uninsured. A lot of them are going to have high deductible health plans. Some of them are going to have what might be thought of as more comprehensive health insurance, but for whatever reason, their insurer doesn't cover particular treatment, or the provider they want to see isn't in network, and they decide it's worth their own money to go out of network or get that treatment that the insurer won't cover. That's the self-pay market. And of all of the characteristics that define this particular free market in healthcare, I think that the one that stands out above the rest is simply the idea of prices. As Dr. Nunemaker was describing his practice, I hope the thing that really struck you was that he has a very clear, obvious price. If you want him as your doctor, you pay $50 a month. That's it. Note what's missing from that. There's no discussion of deductibles or copays or coinsurance. There's no pre-authorization. There's no formularies. There's no waiting months to find out what your portion of the bill is. There's no in-network versus out-of-network. There's him, there's you, and there's your wallet. That's your healthcare system. Now, obviously, a practice like Dr. Nunemaker's focuses on the primary care. And it might occur to you that, well, okay, primary care, I can see how this can be carved out of this entire third-party payment system very easily. But what about more serious things? You're talking about surgery, cancer, heart attacks, treatments for those types of things. Well, I can tell you that there is a thriving free market in just about every corner of the medical system for those types of treatments. Just in the area of primary care that Dr. Nunemaker is in addition to direct primary care practices, there are retail health clinics like Minute Clinic that a lot of you have probably seen, maybe even visited. There's telemedicine services like Teladoc, where you can call a doctor on the phone who, for fairly simple ailments, don't call them if you have your arm, your bone is sticking through your skin or anything, but for fairly simple ailments, you can get a doctor on the phone. They'll write you a prescription. You can go and get that condition taken care of. There are cash-only doctors that charge basically on a fee-for-service model, where you show up, they sew up your arm if you have a laceration, they give you a price, you pay it, and that's it. And of course, there are also urgent care clinics that are sort of a step below emergency rooms, where you can go and save a lot of money going there instead of an emergency room. When it comes to your more serious medical conditions, such as surgery, there are places like the Surgery Center of Oklahoma and Regency Healthcare in New York City that offer what are essentially all-inclusive prices for treatments. That means there's one price that includes everything. There's not a hospital bill that has 720 different line items. There's a single price for hernia repair or heart bypass surgery or hip replacement. One price covers everything. You pay that, and there's no additional concerns, no additional billing. There are websites like one called MetaBid where you can put whatever medical treatment it is that you're seeking, and doctors from around the country will bid on providing you that service. So if you know that you need a rotator cuff repair, you can put that on MetaBid, and orthopedic surgeons from around the country will bid on that, and you can accept whichever one of the offers you like. If you want to go with the lowest price, that's fine. If you want to go with one that's more convenient for you because it's in the same state, you do that. You can also pick one that's based on quality. This guy graduated from Harvard. This guy graduated from, Haitian State Medical University. Whatever criteria you want to use to determine which offer you want to accept, you pick. Another option is overseas medical tourism, where patients can go overseas and get treatment that costs them a fraction of what it costs in the U.S. One gentleman was quoted something like about $190,000 to have a shoulder repair surgery here in the U.S. He went to India, and I think it was about $18,000 that he paid. And for treatments where the free market hasn't fully developed yet with transparent and comprehensive pricing, which cancer is probably the biggest one, that one still has not yet fully developed. But there are companies out there that will negotiate in advance or even during or after treatment has been concluded, prices for you for that treatment. There's free markets in prescription drugs, in imaging, in lab tests, pretty much everything that you might need in terms of your health care. It exists in the free market. And I should probably mention that in this free market, the prices that people pay generally are far less than what people with insurance pay, particularly when you start to include the premiums, the copays, the deductibles, the coinsurance. I can tell you about a primary care doctor in Texas that will see any of you for $30, and he'll see you probably on the same day. That $30 is probably less or about the same as most copays, and for somebody who has not hit their deductible yet, that $30 is certainly less than what you're going to pay to go see a primary care physician. One of the primary reasons for these lower prices, and Dr. Nunemaker touched on this, is once you get rid of a lot of that third-party billing, administration, the coding, the fights that doctors' offices have to have with insurance companies over whether something was correctly coded or pre-authorized in the right time frame. Once you remove all of that, the doctors no longer have to build that into their price. They no longer have that overhead. And I also want to point out that the people who are participating in this free market that exists today range all up and down the income ladder. You have poor people, you have middle-class people, you have wealthy people. It's not something that is just for the wealthy. So the free market in healthcare that exists today can basically be summarized as offering accessible, high-quality, affordable care and ensuring that the treatment decisions are made between the doctor and the patient without a third-party bureaucrat looking over and saying, that's not on the formulary. We don't approve that particular type of treatment. So what's not to like about that? Well, it actually turns out there are some people that don't like that, and I think it's largely based on some myths or misunderstandings about healthcare and free markets, and I'd like to quickly address a couple of those. The first myth is that healthcare is so expensive that only the rich could afford to directly pay for serious injuries or illnesses in a free market system. Well, the heart of a free market system in healthcare is, in fact, patients paying directly for their healthcare, but that doesn't mean that you have to necessarily dip into your savings or pay for it out of your own income. There are insurance and insurance-like mechanisms out there that will actually provide the funds that are necessary to a self-pay patient that keep them in that role of being the person directly purchasing it, but ensuring that they don't have to take out a second mortgage for their heart surgery or whatever it is. For example, there's something called health sharing ministries. These are organizations, they're voluntary associations of people who agree to share medical bills amongst themselves. It actually functions a lot like insurance, but it keeps the individual patient in that role of directly purchasing their health care. There's also something called critical illness insurance, which will pay people money if they are diagnosed with a particular illness or condition. Like heart disease or cancer. A simple way to think about this one is to ask yourselves the question, if somebody gets diagnosed with cancer and they need $20,000 to pay for their treatment for that cancer, if they have a critical illness policy that's going to pay them $25,000 if they get diagnosed with cancer, Does this person actually have a problem funding their health care? I would say no. They had a condition, they have a condition, they got money to pay for that condition. There's no problem at that point. You don't need Blue Cross Blue Shield or Aetna to come in and manage the payment of that once the person has the money in their hands to pay for their treatment. There are also ways that even in the current system that patients who are in sort of traditional conventional health insurance can take advantage of this sort of buying opportunity. For example, there's something called reference pricing. And this is basically, there's a number of ways to structure it, but one way is simply for the insurance company, Aetna or Blue Cross, when you get told by your doctor that you need, say, hip replacement surgery, instead of them managing the payment process, they give you a check or a voucher for $30,000, which is about the price of a lot of hip replacement surgeries. They give you that check, and then you go and shop for a surgeon that will perform your hip replacement surgery for $30,000 or less or more. If it's less, you keep the savings. If it's more, you find a better doctor, you think, you pay for the extra cost out of your pocket. The healthcare system for public employees in California actually does something very similar to this, and they wound up saving millions of dollars from the insurance side of things just by doing this with no reported quality issues, no diminishment in the level of care. Another myth is people talk about, well, you can't expect somebody who's having a heart attack to, shop for care. The free market just doesn't work in healthcare because of all of the emergency care. Well, I will grant that nobody is going to be comparing ambulance prices while they're having a heart attack, and that for true emergency care, maybe the free market isn't exactly the right solution. But emergency care is only about 2% of healthcare expenses, according to research by the Department of Health and Human Services. Everything else in healthcare is treatment that is scheduled days, weeks, even months in advance for orthopedic surgery, for cancer care, for primary care, for a wide range of healthcare. All of this is very easy to shop for in the free market system. So I would say if you have a concern about emergency care, okay, maybe whatever policies you seek, that you're looking for, you do need to sort of segregate out emergency care. But for the 98% of healthcare that's not part of emergency care, the free market should not have any real problems. I think I'm going to go ahead and wrap up here and just say, actually I want to make one final sort of comparison, one way to think about this. I think everybody in this room understands that in terms of trying to deal with the problem of hunger in America, collectivizing the farms and nationalizing the grocery stores would be a terrible way to go. And that food stamps, whatever their problems, are probably a reasonable alternative to the idea of collectivizing and nationalizing the farms and grocery stores. What food stamps do is they look at the more or less free market in healthcare, or in food, which isn't totally free market, but largely free market. They look at that free market, and instead of trying to capture it and dominate it and control it in order to feed the hungry in America, they give resources to the poor to allow them to shop for their food in that free market. That, I think, is maybe the paradigm that I hope that you will be thinking about as you go back to your bosses and talk to them about free market healthcare, what it means, what the problems are, what the potentials are. That's the paradigm that I hope that you have in mind when you go to do that. Because, as I said at the beginning, free market healthcare is not simply something that's theoretical. It's something that exists today. I'm in it. I'm uninsured. I have no insurance. I have, however, made alternate arrangements to ensure that if I get diagnosed with cancer or hit by a bus, I don't have to worry about my financing. I know where the money's coming from. It's not coming from a conventional health insurance company. I'm not going to have to deal, or if I'm in a coma, my wife is not going to have to deal with Blue Cross Blue Shield trying to beg them to get the treatment that I need. We'll get the care that I need. The financing will be there. End of problem. So that's what I hope that you'll take back to your bosses. And if you have any questions for me, I'll be sticking around as well and be happy to talk with you. Thank you.
Thank you.
I did have one more thing to say. Sorry, guys. It's very important. I think it's something that's not mentioned at all. Whether it's the cost of healthcare or whatever, the true crisis is actually just the number of providers. It takes 11 years at minimum to train a physician post high school. And at least 2 of my colleagues in my residency class quit practicing primary care after 2 years. They were burnt out. So it took 11 years to get to where they were and 2 years to burn them out. So whether you're talking about the payment or whatever, if we burn physicians out faster than than they last, if we're burning them out quicker than it takes to train them, then we're going to lose them. We have transitioned physicians that are retiring or planning on retiring into this because they actually want to continue to practice. I knew a lot of physicians that closed their doors immediately after the ACA was signed into law. When the decision came down from the Supreme Court, they hung a sign out their door that they were closed. That was it. They were done. They didn't want to even be part of it. So we lost a lot of physicians there, and a lot of the baby boomers are not only hitting Medicare age, but they're hitting retirement age, and some of those are providers. So we're going to lose practitioners. We can't afford to do that. So something I definitely want you guys to take back is I can guarantee nurse practitioners, physician's assistants, they're fine. They're well trained. I have almost twice the training though. So there are things that when people are really sick, cookbook medicine is easy. Sore throat, strep test, positive amoxicillin. That's easy. But when you have a diabetic hypertensive with a stroke that needs something for kidney failure, you're way above the pay grade of some of the mid-level providers. So we need to keep practitioners practicing medicine, aside from just how we're going to pay for it. If you don't make a physician's livelihood and practice worthwhile, they're going to quit practicing and nobody's going to want to go into it. So that's a huge point that nobody really talks about, but I see physician burnout all the time. It's a big issue. So just wanted to mention that.
Thank you all very much. Thank you.